I'll try and keep my comments brief so that we can give time to discuss the success project. I think the challenge for me when you invited me to talk about co-testing is, I don't really envisage co-testing at all, and we really think about integration of services. Could we go back to the beginning? I'm not sure who's in charge of my slides. So if we could go to the next slide, please. So, I don't need to explain this slide to this audience, but UICC is really championing adoption of the global strategy into national action. We don't want this to be something we talk about in global meetings. We need to get this happening on the ground. So we're really pressing governments to make public commitments to the elimination agenda and to girls and women in their population. We're encouraging countries to look at the WHO modelling, take advantage of that, some of the costing tools, to really create a feasible timeline for elimination in their own country. And I think for this community, I'd really like to encourage you to think about how you can work with civil society to really champion the issue of integration of services as we move forward. Next slide, please. So I've got a couple of slides from Doug Lowy, who everyone, of course, knows. And I'd just like to emphasize the catchphrase at the end: screening for the current generation of women, vaccination for the next generation of women. And the challenge in lower income countries in particular is we have to do all of that at once, as well as looking at treatment. So whilst we can talk about integration, there's a lot of things going on in the heads of policymakers when we're starting to talk about this agenda. And on top of that, we get a lot of confusion around what the to-do is, because there is so much discussion internationally in high-income countries around other HPV-associated disease, genital warts, other HPV cancers. This really confuses the agenda when we're moving to lower-income countries where we really want the focus on cervical cancer. Next slide, please. So whilst this is a great discussion for the US and higher income settings, you can see that HIV isn't mentioned here. And so it's already not a conversation that's relevant for countries with a high HIV burden. Next slide, please. So my first message is that civil society is there. They're ready to work alongside you to push for adoption, but also build demand in communities. But they do need your help. They need to be trained and have that technical support. Could you go back, please? They do need your help and technical support to really navigate the science and work on the interplay between those three targets in their own setting. We can't take the cut and paste high-income country positioning, and it's often confusing for civil society, particularly when private sector representatives, I would say, particularly in the vaccination area, are really pushing high-income country agenda with representatives of civil society elsewhere. So in order to really take the HPV/HIV co-infection story forward, it needs to be in country with the country context. And I think there's a long way to go. Next slide, please. You've seen this report from Yung Lin, and one of the key things that was identified in that report is there's such strong siloed thinking from the perspective of policymakers, but also from donors. And that's having implication down to programmatic level, well, where many people we spoke to who worked in reproductive health or HIV didn't actually realize or weren't being tasked by their leadership to look about how they can integrate cervical cancer into their services. And they were quite surprised that, yes, they should be thinking about it, but they hadn't really had that impetus from above. Next slide, please. I just wanted to share a couple of conversations that I've had with civil society groups. Conversation in Malawi where a women's cancer support organization had its first conversation with a women's group working with women living with HIV, because I put them together, and that they needed that impetus to start talking to each other. And they shared some interesting information which might not be completely new to you. But it does show that civil society can start to open up community conversations. They did note that they had pushback from traditional leaders, and particularly men as decision makers in community. They've been able to address that, and they see women living with HIV are readily seeking cervical cancer screening services because they're now informed. But they do have massive challenges. They often have quite a challenge to get to these screening services, as Yingling has already mentioned. They find that staff have rotated to other sites, so the screening isn't available. They find equipment not working or commodities not available. So again, it's a missed opportunity. And sometimes there's just too many women on that day. And I think what we're forgetting is that these women are healthy. They have very busy lives, demanding lives, and we are expecting them to come repeatedly to a service that often is quite concerning and uncomfortable. So what we're finding is we are able to work with civil society. They're liaising between communities and screening locations. They often even provide stopgap commodities or transport costs for women. But these aren't scalable models, and this is what we really need to aim for. And that's why I love talking about Programme Rose wherever I can, because it's not only a great model taking advantage of new technologies, it's also something that's readily scalable. So I think as a community, we do need to really push much harder in creating a positive attitude amongst staff to engage women. And maybe the elimination agenda is that energy that we can inject into the system and really create a new dynamic when women touch the health service. Next slide, please. And that sideload thinking is also very embedded in program leadership. I've been advising on a group in Mali on a pilot service integrating cervical cancer screening with female genital cystosomiasis. And I asked them about HIV testing, although rates aren't so high in Mali. And they said, oh, that's not our job, that's done by another department. And I said, well, how are you going to advise women if you don't know whether they're HIV positive or not? So there's real siloed thinking at program level, and I think it's very much important for our community to start bringing those conversations together. We've talked a little bit about the UK, and we're working with Joe's Trust. In the UK, we've had long-term activity at grassroots level, and they also raise the issue of stigma. There's a lot of fear around the HPV test and being HPV positive, and really thinking that already means cancer. There's also a lot of stigma around being labeled as having HPV and a sexually transmitted infection. And as Yinglin's mentioned, you can avoid some of that, but we need to really work through and have that dialogue with language that's appropriate in the community. And Joe's Trust really also underscored the critical role of counselling throughout the screening and treatment process because of that potential for increased stigma, particularly when you're working with women living with HIV as well. Next slide, please. So I think I've sort of covered that summary slide. It's just a second message to really start thinking about breaking down those silos. Next slide, please. I think some measures presented the 5 Eyes framework that we published just recently to this group in the past, but I really think it's a good way of reflecting on all the aspects that come together for the integration story, particularly around the HIV HPV co-infection. So I just wanted to flash that back up again. Next slide, please. So in summary, for me, I think the elimination agenda is really a great opportunity to take a fresh look at how services are being run and really thinking about building the enabling environment around that service. So I really encourage you to try and bring civil society into that process. We need some very good implementation research in communities with women and looking for those scalable models of care. We need to make sure we balance the language to avoid building on stigma and shifting the community to a prevention mindset. For us, integration goes beyond just adding cervical cancer and HIV services here. We need to find every touch point, those rare touch points for women with the health service, and make sure they get information on cervical cancer screening. So I think it goes beyond a pure co-testing arrangement. And we need to recognize that cervical cancer is driven by poverty, and we need to get access for poor and vulnerable groups being the priority, rather than something we look at once we've got the urban settings covered. And I just want to not forget that we do need to look at the continuity of care, and particularly the unmet need for palliation in low middle income countries. You know, many of our diagnoses at screening will be for cancer, and unfortunately will also be for quite advanced cancer for some time. So we must push that story forward as well. Next slide, please. So I thank you for your attention. I hand over to my colleague Lisa Huang. UICC is very happy to be a partner on the Success project, and so I hand over to her to give some details of how we're looking at these activities in 4 countries. Over to you, Lisa.